Well, welcome to Science Cafe, New Hampshire, Concord. My name is Dan Marchek. I'm one of the co-founders of Science Cafe, New Hampshire, along with Sarah Eck, my partner from Hopkinton. And we're so glad to see such a big crowd. We're reopening Science Cafe, New Hampshire in Concord because we have David working here. And obviously there's an appetite for this kind of conversation, so I'm very pleased to see so many people.
The idea is to create an informal environment for you to all feel comfortable asking questions. So we've got a bunch of experts here on the topic of opioids, heroin, and addiction, and I think we're going to let Dan finish. Because there's so many new people, the way it works is there's no PowerPoint, we stay away from politics. This is about learning about science and asking about things from a scientific perspective. So it's a question and answer period. Our goal is to have the time together answer the questions that you have. So we bring together some distinguished experts and let you have your chance to ask them questions. We are fortunate to have David Brooks of the Concord Monitor as our moderator, and he'll do some introductions of the panel and talk about the topic. But we just wanted to take a minute and thank you all for coming and sort of give you a lay of the land for how the session works, and hopefully it'll work that way tonight.
So our distinguished panel here, and it is actually very distinguished. This is as good a panel as we've ever had, frankly. Here we have Dr. Thomas Andrew, who is he is the Chief Medical Examiner of the state. He's a person I've called many times as a reporter, so he can tell me no comment. His office is responsible for determining the cause and manner of sudden, unexpected, or unnatural deaths falling under his jurisdiction. He is a licensed physician, of course, certified by the American Board of Pathology. He was a pediatrician in Cincinnati. He worked for the Office of the Chief Medical Examiner in New York City, which must have been exciting. And I promise no one will ask him about any CSI shows. Next to him, some people might recognize here, we have the Concord Fire Chief, Daniel Andrus, who has been the chief here since 2008. And before that, he held a variety of positions in the Salt Lake City Fire Department. He's got his bachelor's degree from Western Oregon University, various master's and certificate degrees from the University of Utah. Next to him, we have Monica Edgar, who holds licenses both as a master-level alcohol and drug counselor and as a psychiatric nurse practitioner. And she has her master's from Riviera down in Nashua, where a college I covered for many years. She has almost 30 years of experience in treatment of substance abuse. She is Director of Substance Use Services at Concord Hospital, leads the treatment team in addressing disorders. And she also has a practice at Riverbend as a psychiatric nurse practitioner, specializing in pharmacotherapy for co-occurring disorders. And on her left is Dr. Molly Rossignol. Is that close enough? No. Who is board certified in both family medicine and addiction medicine. She's practiced family medicine in Concord and Manchester since 2000, works at Concord Hospital as an addiction specialist, and she's also been a member of the Opioid Task Force, part of the Governor's Commission, and she participated in the Naxalone Planning Group and Campaign. And I am actually going to start a question to her, because I'm assuming we're going to charge... before I get to that, let me mention one thing. So Science Cafe is usually pretty lighthearted, because, the point of this is that it's as much fun to talk about science as it is to talk about celebrities or sports. So we'll have some jokes and stuff. Having said that, I realize that the topic tonight is not very lighthearted, and so I hope nobody takes it the wrong way if we are a little fun about it.
It's been only in the past approximately 5 to 10 years that we've really been uncovering the portions of the brain that addiction affects, and it's been a very exciting time to learn about the different medications that we can potentially use, as well as the effect that psychological counseling has on the brain in affecting the outcomes of patients being treated.
So can you see it physically on a brain scan? Can you say this brain is addicted and this brain isn't?
There are brain scans that are done, and yes, the answer is yes. On MRI scans, there are specifically, I'm picturing in my head, first of all, the area that addiction affects the most, and there are different areas, but the areas that are affected are, the one area is called the midbrain, and within the midbrain are several different brain areas that that produce different neurotransmitters. Sorry.
Go ahead and be technical.
Okay.
That's fine.
Different transmitters, and the circuitry there specifically is seen to either light up or not light up, depending on the substance that it's been exposed to, depending on the amount of time a substance has been exposed to the brain. And then you can even, after someone's been in recovery for a period of time, you can also do MRIs and see the difference, where they've actually come back very similar in terms of blood supply and various tagged neurotransmitters.
So you say that addiction is a disease. How do you get it?
In general, it's felt that there are a couple of ways that you can get it, if you will. Certainly, we talk about vulnerabilities. People, we have a certain subset of the population who are vulnerable to addiction, and those would be people who may have a significant family history and genetic components, and those are the other components that are being elucidated. We're learning more and more about the specific genetics. The other thing that we know about addiction that influences its development is the environment in which people are either exposed to, and inherent. That is something that we call epigenetics, to be scientific, and that's the influence of the environment on specific genetics as well. And then the third one that we know it's not a predisposition, but it's actually, if you want to call it a cause or a falling into addiction or developing a disease, is the exposure. So somebody who repeatedly is exposed to a certain drug has a higher risk of developing addiction too. There's no specific test. I have heard people say, oh, there's genetic tests, and I spent a year last year with only addiction specialists, and I went to every conference there was last year, and I've not. There are identified, as I said, genetics, but that does not predispose. That doesn't mean that somebody is absolutely going to have the disease of addiction. I would look more to genetics in general. I mean, I don't have to look far in my family tree to find somebody who has been affected by addiction.
We've all read and heard a lot about overdosing in New Hampshire, the problem of overdose, and I'm curious to know what does overdose mean, and why do some people die from an overdose and some people don't? What physiologically is going on?
Once again, you'll never hear our office use the term overdose because I, like you, don't know what it means. If you look at our death certificates in drug-related deaths, they will say something like acute intoxication due to X or X and Y or X, Y, and Z. 60% of our drug intoxication deaths are multiple drugs. The reason I don't use overdose is that the actual amount that will kill one person versus another person is a moving target. It largely depends on how habituated they are to the drug, how much of the drug that they used at the time of the fatal episode. And that's even further obscured by the level of drug that we are able to detect in the person after death. The wild card there, the unknown to us, is how long it was between the time of snorting, injecting, smoking, ingestion, whatever, and the time that they actually died. So they can be in coma for hours and that drug continues to be metabolized. Attorneys love to play with that, right? Well, that's not a fatal level. Well, it's a dead person. And they've got no other competent cause of death, I'm jiggy with that. That's the cause of death. So overdose is a colloquial term to me, and that's in the eye of the beholder. To me, if they've died due to the effect of a drug, that's an acute intoxication.
We do use the term overdose, and we wiggle out of that by calling it a provider impression. And that's because the patients we see, we usually get them for less than half an hour. And most of the folks that we see with this are strongly incentivized, or at least believe they are incentivized, not to tell us the truth about what's happened, So they will deny drug use, even if we get there and they're unconscious and not breathing, and they are subsequently awakened by the miracle drug Narcan. They will continue to tell us, no, I didn't take anything at all. I've been at paramedicine for 31 years. That's one of the things that has remained absolutely consistent across those years is the degree to which people who have taken a substance will deny it. So sometimes it's patently obvious, and that's why we do use the term overdose, but sometimes it's the best guess, and sometimes it's right out there obvious in your face.
I can say right now I'm actually working with two young folks from this area that did overdose and were revived by naloxone and now are in treatment.
So for those who don't know, just in case, the fire department obviously does at least as much medical emergency work now as putting out fires. And you are a paramedic and have been for 30 years. So your experience here is that you're often the first people on the scene for a alleged overdose.
I've heard Manchester, Laconia, Nashua, but my question is this impacting Concord?
I am glad that I ran the statistics last week. We've seen the provider impression of overdose go up about 600% in 3 years. Now, that said, it is leveling off because last year we saw 148 impressions. This year it went to 151. So it really sailed up through 2014. It's leveling off. At 151, we're seeing a few a week, which is still not nearly the level that is being seen in some of the larger cities in the state, and certainly some of the areas south of the Massachusetts border. But it's high for us. And the concern is that certainly getting out there and stopping it, and we're just beginning to see the encouraging signs of a plateau in Concord. But our providers will tell you that it's sporadic, and you can go a couple of weeks, then you'll have 2 or 3 calls, and sometimes you'll have back-to-back calls as the drugs get out on the street and into people's veins.
And are these overdoses all heroin opioids? Are they all the MAP has the drugs that make up the deaths, the overdoses?
They're mostly heroin, and the scary thing is that fentanyl, which is 80 to 100 times more potent than heroin, is becoming much more common. And back in the day, we used to say that a dose of Narcan between 0.4 milligrams and 2 milligrams virtually woke up everybody who'd had an overdose. And now we're seeing doses probably 3 times that level because of the more potent combinations. And the other side of that coin is they're much, much more deadly.
Excellent. All right. Nope, way behind you. Nope.
Hi. Can you explain specifically what Narcan does, how it gets a person to withdrawal instantly, and how soon after an overdose do they need to be administered the Narcan?
Actually, before that, why don't somebody tell us what heroin does in the first place and what causes the need to give the Narcan?
Okay. We're talking about a class of drugs called opioids. They include morphine, heroin, codeine, oxycodone, hydrocodone, etc. Many in either used for cough or pain. Those generally are the uses, the medical uses for those medications. Obviously, heroin is a Schedule I, so it's not thought to have any medical use at all. What these do is they bind to receptors in our brain. Well, the receptors are found in our brains, a couple places in our brains. They're found along our spinal cord. They're also found in our gut. So if anybody's had an injury that you've had to use them, you've probably found yourself constipated because they slow the gut significantly. So they bind to those receptors called mu receptors. And what the other place that in the brain, and this refers to overdose and Narcan, that these receptors are found are in the respiratory sensor, if you will. And when heroin is taken, or morphine or anything, my patients who I've seen, who I'm treating, will say it makes them feel like it's a nice warm blanket that comes over them, all right? I remember being 18 and having taken one Darvocet and just made me feel like I couldn't open my eyes, and I hated it. But And for some people, over time, or even the first exposure, that's the feeling makes them feel okay and normal. But primarily, it's a pain receptor. It stops pain from going up the spinal cord, stops pain from going down. So it's basically eliminating pain. The way that it fits, I think of kind of have to use my little thing. It's like this is the receptor. It fits perfectly into that receptor. It's called an agonist. And I always think of it as like pressing a button at the bottom of that receptor, it turns it on. So heroin will do that. The Narcan, or what naloxone is an antagonist. It does absolutely the opposite. It turns it off. And it does not fit nicely. It actually covers it and blocks any other opioid from being able to fit itself into that receptor. The, I guess, fortunate thing about naloxone is that it's stickier, and it's much more what we call, it has more of an affinity for this receptor than any other opioid does. And so if somebody has heroin on board and it's squelching their receptors and as well as the respiratory system, and they're stopping breathing, Narcan can be administered and rapidly just scoops it right out of that receptor, and it wakes them up immediately. So it's kind of an interesting, it's an agonist-antagonist effect.
So if Narcan basically bumps or takes over the receptor for the heroin, does the person come, because I've read a lot about this, that the person comes into instantaneous withdrawal and is potentially violent and potentially could be hard to deal with? And so one of the reasons why a lot of people didn't want to give it to people, like to parents or to loved ones with an addiction, is because they didn't know how to deal with a person withdrawing to that extent. And does that happen? Is it an instantaneous withdrawal, and are the people hard to deal with, or is that just...
Yes. I'll share a story. I have only been hit twice in my career. A lot of people find that really surprising. I think there are a lot more that wanted to, but only 2 patients have actually connected with my face. Both seem to enjoy it, so hopefully it doesn't catch on. But one of those was a young man who, upon our arrival, was not breathing and completely unconscious. And we supported his respirations with a bag mask for a couple of minutes while I got an IV started. And I gave him 2 milligrams of naloxone, and he snorted awake, and within the space of about 3 seconds sat up, punched me, knocked me over on my back, grabbed the IV bag, and jumped out the window. My partner, who refrained from laughing, showed a lot of restraint, just said, next time give it a little more slowly. And that word that they teach you in paramedic school, titrate, wake them up slowly. One of the pieces about naloxone that needs to get out, yes, it's a miracle drug. It does wonderful things to the patients, but it also takes away that high, and it can induce a really potentially violent withdrawal reaction in them, which is both physiologically and psychologically traumatic, and it can be dangerous for the people around them. So my caution, and my nose aches when I say this, be careful with that stuff.
So I'm just curious, I think I heard a little bit, you started down this road, but I'm just curious how specifically, sort of biologically, what's happening during an overdose? I mean, what kills you in an overdose?
In addition to stopping pain, it also will, it being an opiate or opioid drug, will substantially reduce your respiratory drive, your reflexive in and out, up and down of the diaphragm. The more prolonged that respiratory depression is, the longer your brain is deprived of oxygen. Tissues, you can write this down if you're taking notes. Tissues do not do well without oxygen. Once that vicious cycle starts, then entire systems will shut down. It will generally trigger enough hypoxia, or lack of oxygen in the blood, will eventually trigger a lethal ventricular arrhythmia, meaning an electrical storm of the heart, and will stop the heart. or it will trigger a lethal bradyarrhythmia, meaning a slowing down enough of the heart rate such that it comes to a stop. So it's the lethal mechanism is primarily respiratory depression. I would defer to others if you have other thoughts about that.
So what do you see in an autopsy that makes you say, the primary cause of death was that the lungs shut down?
Well, that's an easy one. You don't see anything. You see signs and findings that are suggestive of, but not diagnostic of. The proof in the toxicology pudding is in that blood level that you have that the laboratory will detect post-mortem. What I see with the naked eye, I may or may not see recent injection sites. I may or may not see nasal inflammation from snorting the drug. I may or may not see a great deal of what's called pulmonary edema or fluid flooding the lungs. That may be so dramatic, such as to well up out of the airway and out of the nose, and when they're found, they have this big plume of white foam coming from their mouth or nose. The doctor mentioned the constipation. I will haul bricks of weeks-old feces out of the colon because of
Anybody want any more dinner here?
because of the long-term effects of the opioids. The bladder will be distended up above the pelvic brim by 400 and 500 milliliters of urine. It is a myth that the bowel or the bladder will give way at death. That's a wives' tale. But we will see hundreds of milliliters of urine in that bladder that is also prohibited from emptying. Those are only suggestive signs and symptoms. The bottom line is what you detect in that person's blood post-mortem.
All right. I'll come over here in the middle.
Are there correlations, either anecdotal or scientific, between certain mental health issues and opioid abuse? And I'm thinking specifically, obviously, of depression, but also bipolar and schizophrenia.
Excuse me. I know with schizophrenia, there is and bipolar disorder type 1, so the more severe type of bipolar disorder, that there is a higher likelihood that somebody can have a substance use disorder. In schizophrenia, it's 75%, and I think in bipolar disorder is up there too. I can tell you at Concord Hospital and Substance Use Services, in our IOP, we see almost 300 patients a year, and about 60 to 70% of them have a co-occurring disorder.
Actually, that phrase, can you explain what that means?
Sure. Co-occurring means that they have a psychiatric disorder as well as a substance use disorder.
And I'm sorry, 60 to 70% of the patients you see have both?
And that's about national average in any outpatient treatment program for substance use disorders. You'll see that 60 to 70% of folks having a substance use disorder and a psychiatric disorder.
And so is it that people with a psychiatric disorder are more likely to take drugs to try to cope, or is it that there's
various theories about that? Yes, to cope, to manage. They're also vulnerable genetically, their environment.
I also want to say that if somebody has a primary addiction, as I said, it's a primary disorder, that can also look like a psychiatric disorder. And in fact, in withdrawal states, we might see somebody who looks, for all intents and purposes, incredibly depressed, like suicidal depressed. And that really needs to be paid attention to, but that may not be depression. That may be withdrawal and needing to wait for that withdrawal to subside or to improve.
Well, the follow-up?
By way of a follow-up, are there correlations between alcohol abuse / alcoholism and opioid abuse?
So this is something that I'm using more of an observation study in my practice. The short answer is yes, because anybody who has addiction to one is at higher risk for developing addiction to anything. I failed to say that the common denominator frequently in addiction for a neurotransmitter is dopamine, and opioids really great at just pouring out dopamine. Cocaine and methamphetamines are better, but opioids do a good job of it.
And dopamine is the feel-good?
Dopamine, anybody who just had a burger has a ton of good dopamine going on right now. And it's a feel-good that's released with really laughter, eating, sex, etc. But using substances kind of just drill right to the source and release that. So there's certainly an association and a risk with somebody who has alcoholism and opioids. What I've found in my practice that it was really interesting to me and opened my eyes is folks who come to see me for, say, a heroin use disorder, opioid use disorder, looking for treatment, they've already blasted through their alcohol history. They've already blasted through their alcohol history. They may have dabbled in it as a teenager, maybe some in college, but I mean, frequently I'm seeing folks who are 20 to 25 years old, so they haven't even gotten out of their adolescence practically. But suddenly, alcohol doesn't matter to them because there are very similar pathways. Alcohol kind of sprinkles itself around the brain. Opioids, as I said, have the mu receptor, but alcohol does affect the opioid receptor as well. Opioids just do it better.
Well, I'm going to keep asking questions. There we go. Wait.
Go for it.
Okay, you sure? All right. Well, this is going to be a little heretical, I think, but in light of the fact that what is causing addiction to some degree is this desire for pleasure, what is being done to perhaps produce safer drugs that people could be addicted to and not die? Is that an absurd question?
They legalized it in Colorado. Yeah. I didn't say that. I'll just say from American Society of Addiction Medicine, that wouldn't be one of our one of the plans. So, yeah, there are other things that people can get addicted to, if you will, that I think are pretty darn awesome. And when you look at the whole picture of addiction, though, we're talking about the slice, the science, the biologics, etc. But we know that addiction affects people from the psychological, spiritual, and just mental effect as well. And it doesn't matter what you're addicted to; it can really ruin your life. So, yeah, correct. Your families, and it affects your friends, etc. Somebody can be addicted to work and never go home, and that's going to be pretty devastating. So I'm not sure that looking for a drug that's safer to be addicted to, I'd tell somebody to go for a run.
So please join me in thanking our panelists. And our moderator, David Brooks.